So good evening to everyone who's logged in. It's my absolute pleasure to invite you all to the second edition of the conference on cytokine storm. So although we think cytokine storm is a rare entity, I think increasingly over the past couple of years, especially after COVID, more number of people have started recognizing this condition. And because of that, there are more number of people interested in this syndrome as well now. So this time we've tried to focus on all the triggers of cytokine storm and not just limited to infection-related cytokine storm as we did predominantly last year, and also go into a bit of the depths of management of this intriguing condition. So a few housekeeping rules before we proceed. I request all of you to kindly keep your cell phones on silent mode. If you have any questions, please post it in the chat or the Q&A box. And between the chairpersons and I, one of us will try to take up your question if time permits. And with this, I now request Dr. Rakshay to kindly give an overview of the program and of the proceedings as well. Thank you.
Thank you, Dr. Chandrika. On behalf of the organizing committee of this conference, I welcome all of you, all the faculty and delegates. So during the COVID pandemic, two things happened. One, the term cytokine storm became popular, and others, virtual CMS became popular. So catching on the same theme, we had a first edition of CRS last year, and it was a huge success. The idea behind hosting this meeting was to get an expertise from different areas of specialties, from intensive care, from rheumatology, from hematology, and from infectious disease specialists, to see how we can care for the sick children much better. Now, currently in India, we are in middle of one more viral infection season. There's plenty of adenoviral and flu infections creating havoc across the country. And I hope a lot of things what are going to be discussed in this meeting in the form of the talks, panel discussions, as well as the debates and case discussions would give a lot of insights for all the pediatricians and the intensivists and neonatologists and rheumatologists managing sick children in this country. So with that, I would like to welcome Dr. Dinesh Chilla. Dr. Dinesh Chilla is the head of and director of the Pediatric Intensive Care Services and the Newborn Services of Rainbow Children's Hospital. Apart from that, he's currently the chairperson of IAP Pediatric Intensive Care and is going to be a vice president of NNF. So he's a very popular pediatric intensivist and neonatologist with more than 64 publications to his date. I would request Dr. Dinesh Childra to address the gathering and start the proceedings.
Thanks, Rakshay, for the kind introduction. Good evening, everyone, and welcome to this fantastic conference on cytokine release syndrome, the second edition. The first edition was a huge success, and I welcome you all. Have a great learning for the next 3 days. Let me take this opportunity to congratulate the organizing committee, both Dr. Rakshay Shetty and Chandrika, who took great efforts to sort of, get everything together. From IAP Intensive Care chapter, we post-COVID, we started facing a lot of challenges and have started understanding cytokine release syndrome a little bit better now. But as Rakshay was telling, we probably saw all the types of viruses this year. We saw dengue, we saw adenovirus, we saw influenza, and we started realizing that, this type of inflammatory syndromes we are seeing post other viruses also. And different age group, the presentations are different, the challenges are different, the management challenges are different. And thanks to the organizing committee, they got the experts from across the world for this fantastic conference. So without taking much time from the academic these things, I welcome you all for this conference and back to the organizers for the first session on cytokine storm.
Thank you, sir. So I would like to now welcome our chairpersons for the first session. So apart from Dr. Dinesh, who's already been introduced, we have Dr. Jagdish Chinnappa. He's the cluster head of pediatrics at Manipal Hospitals, Bangalore, and he's been the past president of the respiratory chapter and the CEO of Bangalore Medtrain LLP. And Dr. Basava Raj, who's the professor of pediatrics at Indira Gandhi Institute of Child Health, Bangalore. He's also the IAP National President-elect for 2023, and he's been the National Honorary Secretary of IAP for the year 2021. I welcome both of you along with Dr. Dinesh to chair the first session. Randy Cron as well, who's the first speaker for today. So actually needs no introduction in the world of rheumatology. So he's the director of pediatric rheumatology at University of Alabama at Birmingham. He has many publications to his credit, and he's in fact even published a textbook on cytokine storm, which is very widely read and still holds a lot of relevance to most of us. And his lab focuses on the role of heterozygous mutations in familial HLH and genes contributing to cytokine storm. So he has a great interest in this syndrome, and I don't think we could have had anyone better to kickstart this symposium. Over to you, Randy.
Thank you much. I will try sharing my screen here. Very much for the invite. I really enjoyed the last one, and I'm looking forward to this meeting as well. And we're going to talk about cytokine storm syndrome and what's new. And really, in the brief time I have, I'm going to speak a little bit about therapy and a little bit about genetics of some of the secondary forms of cytokine storm. I do have disclosures that are relevant. And so here's, for those of us who are lumpers of this condition, we are, like was mentioned briefly earlier, we're starting to see a lot of different etiologies that can contribute to kind of the end common product of the multi-organ failure that we see in cytokine storm syndromes. And as rheumatologists, we are certainly aware of children and adults with Still disease or systemic juvenile arthritis, lupus-triggered cytokine storms or macrophage activation syndrome. Our hematologic oncologic colleagues will certainly see various hematopoietic leukemias and lymphomas that can result in this, as well as iatrogenic treatment for refractory disease with things like BiTE or CAR T-cell therapy leading to cytokine release syndrome. And then there's, of course, a large Venn diagram circle of infections that can yield this as well, primarily intracellular pathogens, mostly viruses, but unique bugs like Ehrlichia and Leishmaniasis can do this. And the viral category, the herpes virus family is, of course, probably the most notorious, including Epstein-Barr and cytomegalovirus, CMV, HHV6 and 8, etc. But also bad strains of influenza, hemorrhagic fever viruses like dengue, and our new friend on the block, COVID-19. Not for all cases, but certainly some of the more severe hospitalized cases. But even more compelling probably is these children who develop the post-COVID multisystem inflammatory syndrome and children who get a pretty quick cytokine storm syndrome-like phenotype. So again, those of us who lump these disorders, they're not all the same. They should not all be treated the same, but they do have some end common pathway features. And that's kind of depicted here. So there are multiple pathways to get to this place that we're trying to avoid. Probably the best studied and perhaps the most common are these genetic defects in the perforin pathway. But we also have some rare genetic disorders as well as Still disease, where increased levels of the IL-1 family member interleukin 18 are noted, and those likely need to be treated by blocking that if available. Again, there are a large number of infectious triggers and then these iatrogenic causes, as well as some rare metabolic disorders and even things like cardiac bypass, including ECMO, can trigger some cytokine release. And so first I want to talk a little bit about the drug anakinra. It's a recombinant interleukin-1 receptor antagonist that many of us have found to be quite useful for many of these patients. And my colleague Wynn Chatham on the adult rheumatology side here at UAB and I started a clinical trial a while back, actually. But as part of that trial, we collaborated with Devin Absher at Hudson Alpha to look by whole genome sequencing at the genetics of some of these secondary forms, which are less well understood. And of the first 5 patients we enrolled, mostly children and adults with lupus, as well as some adult onset Still disease patients, you can see that all of them, of these first 5, had heterozygous, often multiple heterozygous mutations in these perforin pathway associated genes. And that's depicted here. So on the left side of this diagram, this blue cell is either a natural killer cell or a cytotoxic CD8 T lymphocyte. They share the same common perforin-mediated death pathway, in which these cytolytic granules are preformed, ready to go within the cell, and they contain proteins including perforin and granzymes. And when this cell recognizes its target cell and becomes activated, these cytolytic granules will polarize and traffic along the actin cytoskeleton to this immunologic synapse. And in addition to perforin, there's all these unusually named proteins like RAB27A, syntaxin 11, lung13-4, et cetera, that are critical for that process to occur. So in the familial form of this disease, or familial HLH, if you're homozygous deficient in any of these genes, this will result in a cytokine storm. If things go correctly, these lytic contents will be released into the immunologic synapse, and then perforin will form a channel or pore between the killer cell and its target cell, allowing for release of granzymes, which then trigger apoptotic cell death of the target cell, which then actually signals back to the killer cell to go away. So they don't sit there and have prolonged interactions, leading to the excess pro-inflammatory cytokines that are thought to lead to the multi-organ failure. We included a few more patients early on in this clinical trial, and again found a patient with a LIST mutation in this pathway, but also identified this protein DOC8, which was not previously thought to be a cytokine storm syndrome related gene. And since then, we've identified several other children and adults with heterozygous mutations in this gene DOC8, including some from our colleagues in New York. Carolyn Fine-Levy and colleagues identified 4 out of 39 children with this post-COVID MISC who had heterozygous, mostly rare, missense, mostly amino acid changing mutations in this gene. Dr. Chapman and I conducted another clinical trial during COVID to look at the ability of anakinra to potentially help those patients, but again did genetics on a subset of them and found that 4 out of 20 of the patients that we identified had missense mutations in COVID-19, and we identified some MIS-C kids and a few others here as well. And so C42 is a relatively novel cytokine storm syndrome gene that results in high IL-18. It's also a binding partner for DOC8, but DOC8's primary purpose is as a GTPase that is critically important for actin cytoskeleton reorganization. So you can imagine that a defect in this would lead to disruption, for example, of movement of cytolytic granules within a cell. And so we took one of the first mutations we identified, a missense amino acid changing mutation in DOC8, and introduced it into a natural killer cell line NK92 using a fomivirus construct. And these NK92 cells have DOC8 and the killing machinery already available, but we overexpressed either more of the wild type DOC8 as a control or the patient's mutation. And as summarized on the right here, if we look at killing activity on the y-axis and just increase effector to target cell or more NK cells per target cell, you can see particularly at the higher effector to target cell ratio that this patient's mutation is decreasing the ability of these NK cells to kill their target. So we think acting in a partial dominant negative fashion. Similarly, during the process of killing, there is this degranulation assay, which allows you to detect LAMP1 or CD107A that actually just ends up on the cell surface. And so it's easy to detect by flow cytometry. It's probably even a little more accurate than some of the killing assays that are out there. And again, at different time points, you can see that the patient mutation here in gray compared to the wild type gene in black leads to decreased degranulation. And the result of that is excess production of pro-inflammatory cytokines, including TNF or interferon gamma. And so again, I mentioned we did a small clinical trial here in Birmingham on adults with severe, our criteria are pretty strict, cytokine storm syndrome-like disease as part of their COVID. And as part of that, we did whole genome sequencing on 20 of those patients. 30% had a heterozygous, at least one, if not more, mutations in these familial HLH genes. And this number, 30 to 40%, we often see in cohorts of secondary cytokine storms, but also 20% had, or 4 of these 20 patients had a heterozygous mutation in DOC8. We also, through colleagues, identified another patient at another institution who had early on during the pandemic, a severe kind of cytokine storm as part of their COVID-19 and a novel missense mutation in DOC8. And again, that patient, either by the killing assay or the degranulation assay, had kind of a partial defect when introduced into these NK cells in their killing. And so the COVID-19 patients, the 4 that we identified in our trial, both either by killing or degranulation, had decreased ability to kill when introduced. And then those 4 patients that our colleagues in New York identified in children with MISC had a very similar phenotype in their decreased killing. And so we think that certainly in addition to COVID, but in this case, what we've shown for mostly for COVID and MISC is that DOC8 may be a risk factor for developing that type of severe reaction to the infection or to the post-infectious process. One of the mutations we identified was in a splice site variant, so they're not all missense mutations. My son, who was a high school student at the time, needed a project for his high school graduation. Anyway, he worked with Mingse Zheng in my lab, and we developed a novel assay to explore this splice site variant. And what we did was he took a plasmid that expressed the green fluorescent protein that we could detect by flow cytometry. It's driven by a CMV promoter. And we disrupted the cDNA for green fluorescent protein as if it was a gene with 2 exons and kept it in frame, but separated it with the intron from this DOC8 patient with the splice acceptor site, single nucleotide variant, or from the wild type sequence. The plasmid itself, when introduced into the NK92 cells, is expressed in about 10% of them. And when we disrupted this, but put in the splice acceptor site wild type sequence, we got nice, roughly equivalent expression, if not slightly better, from this plasmid, so that the intron is being spliced out properly, and you get green fluorescent protein. But when we put in the patient mutation, it was completely disrupted, suggesting to us that maybe even not just a partial dominant negative effect, but having less of this protein may be a problem. And so this just summarized multiple experiments confirming what I just showed you. And in fact, there is an assay, an exon trapping, a plasmid-based assay, which is a slightly more complicated plasmid to generate, but it's the more standard version. And it basically gives you the same results, lack of splicing with that mutation. So because the diminished expression, one approach we took was, the NK92 cells have their own DOC8 wild type sequence. And so by using a DOC8 specific sgRNA, we use CRISPR-Cas technology to basically disrupt DOC8 within the NK92 cells. And when you look at killing, so the cells in this kind of pink box are the number of cells that are dying when these NK92 cells are being expressed. So here is the negative control. So you get 30% killing at this time point. When we completely disrupt DOC8, you still get killing. So unlike in a setting, for example, perforin, where you would completely lose killing, there's some redundancy in the system here, but you can knock down killing almost by 40% here. When we introduce back one single copy of the wild type gene, that killing goes back up to 24%. When we put in a patient mutation, it goes up, but only to 21%. So, and this was a missense mutation that we added back. So we do think that having less may be a problem as well. And we explored that by using siRNA specific for the DOC8 message within these NK92 cells. And here, whether we're looking at degranulation is detected by CD107A. When you mix them with the K562 cells and activate them here, this is the negative control. In the absence of K562, as you add in increasing amounts of siRNA to disrupt DOC8 expression, you slightly diminish the ability of these cells to kill and also bring down, degranulate, and also bring down the ability to kill. And so this was enough to finally convince my colleague Ed Behrens at the University of Pennsylvania to explore this in an animal model of a cytokine storm. And in this case, he took the DOC8 deficient mice and used the LCMV model that Michael Jordan had championed back with the original perforin gene. And there are a few things to point out in these mice. So they don't get as severely sick as the perforin deficient mice when they get infected with LCMV. But if you look at their ability to gain back their body weight, you can see here around day 4 or 5, the wild type mice start to gain that back. They're clearing the LCMV infection. The DOCK8 deficient mice are not. They have larger spleens than the wild type mice. They have more severe thrombocytopenia, increased levels of serum interferon gamma, and they don't clear the virus as well. And in addition, they have more liver pathology associated with this illness. So we think there are, like I said, multiple pathways to get to the cytokine storm, including this perforin deficient pathway, which there's genes that are much more clearly identified, but we think maybe DOCK8, maybe on the outer circle here, is one of these potential genes that may contribute in part via this pathway. So, 40 years ago, we didn't really know the genetics of these genes, but now we do for a fair amount, at least of the familial disease. And so perforin deficiency is relatively low-hanging fruit these days. If you see homozygous defects in perforin or syntaxin 11, it's, for example, you're likely to identify it. But that's only 1 in 50,000 live births, whereas maybe 1 in 2,000 individuals will develop a cytokine storm later in childhood or later in adult life. And so these are the harder ones to really identify and to prove may contribute, particularly if they're novel genes, but even if they're heterozygous defects in these same genes that are involved in the homozygous form. DOCK2 is very similar protein, desiccator cytokinesis number 2, to DOCK8. And others have shown in murine knockout models that, that if you're homozygous deficient in DOCK2, that your killing is not normal. And we identified a child who kept getting, unfortunately, cytokine storm syndrome after cytokine storm syndrome in our ICU. He had a short gut and he had a central line, and it was often triggered by a central line infection. But, kids get central line infections all the time. They don't always get a cytokine storm. We could not identify any of the known, including DOCK8, genetic triggers of cytokine storm, but he did have a heterozygous mutation, again, a missense, a rare mutation, amino acid changing mutation in DOCK2. And when we overexpressed that, either the degranulation or the killing assay was slightly diminished. So perhaps for him, DOCK2 is a contributing risk as well. So in addition to anakinra, in some parts of the world, for whatever reason, that drug is not available, but the canakinumab, the IL-1 beta monoclonal antibody is. A lot of times, if you're already on anakinra and you develop a cytokine storm, you can just simply increase the dose, and that will often help. When anakinra is not available, our colleagues in St. Petersburg, Russia, resorted to increasing canakinumab, and that can work as well, particularly for children with systemic juvenile arthritis. There are other IL-1 family members I think that we will be seeing more attention to. Ed Behrens in this top figure showed, and again, a murine model that blocking interleukin 33 in this particular model could rescue survival of these mice. Ed and Scott Canna and others have identified patients with these rare NLRC4 dominant mutations that lead to excess levels of interleukin 18, and there anakinra can kind of stave things off but not really fix the problem, and their IL-18 addition, blockade of IL-18, saved these infants' lives. We know now from the cytokine release story from CAR T-cell therapy and other approaches that are just showing up all over the literature left and right for treating cancers, but are likely going to be treated for autoimmune disease and other things, that a significant percentage of these patients who get these therapies will get these cytokine release syndromes. They need to treat that as well, and IL-6 blockade is now in the US FDA approved for that indication. And then coming full circle with Michael Jordan's perforin mouse study, we now have anti-interferon gamma, or emapalumab, that's been shown to benefit children with actually the familial form that we used to always have to treat with etoposide or VP16. And it's now being tested in children with systemic JA and other conditions as well. So I think anti-interferon gamma will likely be an option for those of us who recognize children who aren't responding, for example, to IL-1 blockade, and or they have indications of high interferon gamma levels, for example, high CXCL9 as an indirect marker. Janus kinase inhibitors are getting attention. Again, mouse models, in this case, in the perforin deficient model, Janus kinase, in particular ruxolitinib, the particular, not all Janus kinase inhibitors are the same, has gotten a lot of attention. And Kim Nichols and colleagues have collected, through the literature, over 100 of these patients now who have been treated with ruxolitinib in particular, and found that it can be beneficial in treating patients with cytokine storms. And so in the past, we were kind of restricted to etoposide. The rheumatologists would sometimes use cyclophosphamide, but these chemotherapeutic approaches, often with glucocorticoids, which are broadly immunosuppressive and sometimes not ideal in the setting of infections. Dexamethasone with its better CNS penetration, but methylprednisolone, more by the rheumatologists, they often use approximately 5 times more corticosteroid equivalent. In the past, calcineurin inhibitors, and I still occasionally use these, such as cyclosporin or tacrolimus, which are broadly going to inhibit cytokine production via inhibition of the NFAT family of transcription factors, are still possibilities, but I think they may be replaced by similar inhibition, which is slightly more targeted at downstream kinases that signal from common receptors to various pro-inflammatory cytokines, like we just spoke about. But I think more targeted approaches, and when we get to the point of really knowing which patients we can treat with which drugs, I think will be very beneficial. So kind of a personalized medicine approach where we're blocking IL-1, IL-6, IL-18, interferon gamma, or others. There are also approaches of broadly removing evil humors like pro-inflammatory cytokines with things like plasmapheresis or cytokine absorbing. And then there's various often lymphocyte depleting or even more broadly depleting like anti-CD56, but targeting CD20, for example, the B cells in EBV triggered disease. And so that's kind of where we've come to. And if there's time, I'm happy to take some questions.
Hi, thank you, Randy, for an excellent lecture, giving to insights about the genetics of cytokine and about the management. The first question was, is every clinical cytokine storm genetically predisposed?
Maybe. I don't know. We often find, of the genes at least we know to look for, that when you look at cohorts and you look broadly, that up to 30 to 40% of people in individual cohorts may have heterozygous mutations. And again, it's controversial. Not everyone believes that they contribute to disease. It's pretty hard to directly prove that. You can kind of show in vitro what we do in our lab. And not all mutations, I show the ones that actually inhibit, but we found some that do not. So just because you identify a gene doesn't mean it necessarily contributes. My guess is not, but because there are some organisms that are probably really highly predispose you to it. On the other hand, influenza, for example, when H1N1 hit in 2009 and people were dying all over the world, often previously healthy individuals from cytokine storms. Our colleagues in Cincinnati, Grant Schuler and Lexi Grom and colleagues, found that slightly more than a third of the patients that were identified in a cohort in Michigan who died from H1N1 had mutations in LIST, which is in that perforin pathway, and 2 of those patients also had a common perforin mutation. So I think there's going to be a large percentage of people who have genetic predispositions, because why is it that some of us who get the infection get sick but really don't get a cytokine storm and others do not? But I'm sure there are other factors as well.
You talk about docket variants. Are they de novo occurrence in your cohort, or what do you think about the docket?
Well, docket is a massive gene, as is DOC2. And so bigger genes you might expect to have more mutations. And for whatever reason, if you just look at the number of mutations that have been reported out there, DOC8, for example, tends to tolerate more mutations, even missense or amino acid changing mutations, DOC2, for example. Again, though, it's very hard at a population level to compare what's out there to what we find in patients with cytokine storms. And so my guess is that many of us, maybe up to 20% of the general population, harbors a missense mutation in some of these more common ones, which are often, when you study them in the lab, less aggressive in terms of the amount of inhibition they incur on cytolytic activity, for example. So, for example, the perforin A91V mutation in some populations is around 8 to 10% of the general population, although our group and certainly several other groups before us and after us have shown that that particular mutation probably does partially disrupt cytolysis via cytolytic lymphocytes. So, you know, my personal bias is yes, that these things, including DOC8, can contribute, but not every mutation you identify is one of those. In fact, that very first DOC8 mutation we found in the clinical trial has minimal effects, and it's also present in 12% of the population. So it's unlikely to have a large effect. It may have a small effect.
I think the two questions I'll try to combine about the therapy. See, what do you routinely recommend doing genetic evaluation? Number one. Does it help in your choosing the therapy? Like based on the mutation, we talk about DOC8, we talk about DOC2, and do we decide, what therapy to be used, or what are the other methods? We talked about so many different types of therapies we talked about. Are there any other clinical or laboratory parameters which help us to choose which is a good therapy or immunomodulation for children with cytokine storm? Sorry, I think combine 2-3 things, but the main thing is genetics. Do you do routinely? Does it help in choosing the therapy? And second would be, if not, because many of us are not doing it as a routinely, or it has not become a clinical norm yet, what are the clinical and laboratory parameters which help us to choose which immunomodulation to do?
I think at this point, we're not quite at the precision medicine approach to know that when you have a genetic mutation, number one, again, you have to, unless it's been reported before, it's hard to know even if that mutation does anything unless you bring it back to the lab. So it's a lot of kind of brute force at this point. So I don't think it really helps. I do it on as many patients as I can because it's my area of interest, and I think we learn from it. But whether it helps the individual patient, probably not. And I will say that many of these secondary forms who have heterozygous mutations may never get it again, unlike that child with the DOC2 mutation who had a recurrent trigger through central line infections. Most people who we identify with these heterozygous mutations, even ones where we show they have dominant negative effects, tend not to get it over and over again if their defect is moderate to mild. So I don't think it's necessarily going to help you, although if you want to consider genetic counseling, and I've had that show up even from patients who have now gotten old enough to have children, but I don't think acutely it's going to help you. In terms of which therapies, I typically start, if all things are unknown, for the most part, with IL-1 blockade using anakinra because it's a safe drug, it's a fast-acting drug, and it works for a lot of patients. But at the same time, I do send off CXCL9 at the very beginning because that can come back, depending on where you send it, within 2 or 3 working days. And then if your anakinra, for example, is not helping, but your CXCL9 levels are very high, then that may guide you to use emapalumab, for example. IL-18 levels are not easily measured. We'll probably hear more of that from Scott Cann et al. But that would be another way to potentially guide your therapy if you had very high IL-18 levels, and certainly if you had a genetic. So here's where genetics would help you. So if you identified, for example, an NLRC4 mutation, sure, that would be very helpful to know. Some of these rare autosomal dominant mutations that, yeah, you're going to likely need to use IL-18 in that setting. But for the most of the ones, I'm not sure the genetics will help you up front. XLP is another place you can look at protein levels in a shorter term, I think, than genetics. But X-linked lymphoproliferative disease is another place where genetics may help guide you, particularly if it's Epstein-Barr virus driven, where you may then just go straight to rituximab. Measuring IL-6 levels may help guide you for things like cytokine release, but you kind of already know what you're doing there by causing it if you're using those types of therapies. But IL-1 blockade may be valuable there too. So it's kind of a wishy-washy answer, but I think we're getting better at trying to define which of these drugs are going to help which of these patients. And genetics will help in some rare cases, but probably not so much for many of the secondary forms, at least at this point.
No, I think with the familial HLH, what is your experience with ruxolitinib, the kinase inhibitor, Jake? Have you been
I
using?
personally have never used a Janus kinase inhibitor for familial HLH. That's not to say that it wouldn't be helpful there. It would seem like it might, particularly if interferon gamma is one of the ones that the JAK inhibitor is inhibiting. I know of a few cases where even just anakinra alone has helped familial HLH, and we now know that emapalumab can help familial HLH. So it wouldn't surprise me if a Janus kinase inhibitor was a reasonable therapy for that. It's certainly not standard of care. I'll leave that up to the hemato-oncologist at this point. But I think, we're going to continue to get farther and farther away from chemotherapeutic approaches. That's not to say that there won't be patients who are refractory to all the things we use, and they will still need those potentially.
So you're saying emapalumab can be used in familial HLH. You have some experience in using that?
I don't personally, but the New England Journal paper is out there, and it helped about 2/3 of the children in that trial, some of whom were refractory to etoposide, others who were not.
Yeah. Just the last question before I hand over to this. So those who have docket mutation, are they generally immunologically predisposed to more viral infections, or just some viruses trigger this inflammatory storm?
Yeah, that's a good question. Well, I'm not a microbiologist, so I don't study infection per se. That's something we could do, in the murine model. And so when Ed infected the DOCK8 deficient mice with adherents with LCMV, they did not clear the virus as well. So if it's similar to what's going on in the perforin deficient mouse, yeah, you may not clear the virus as well. And you also may end up triggering a cytokine storm syndrome.
Thank you, Ryan. Thank you so much for your valuable input. I hand over back to Chandrika for, I think, I think, I don't know whether how are we placed with the time? Yeah, back to you, Chandrika.
Thank you so much. I would now like to request Dr. Jagdish Chinnappa to introduce our speakers for the next talk.
Thank you, Rainbow team and Chandrika, especially for this invitation. We have a very interesting debate for about 30 minutes now. The debate will be on criteria for cytokine storm, boon or bane in real life scenario. And we have two very eminent people who are going to speak for and against. We have for Dr. Scott Khanna, and against will be Dr. Ashish Kumar. Dr. Scott of Pediatrics, University of Pennsylvania, Perlman School of Medicine, attending physician, pediatric rheumatology and immune dysregulation, Children's Hospital of Philadelphia. He's a physician scientist and a practicing clinician in pediatric rheumatology and immune dysregulation. I will go to Dr. Ashish Kumar, who is the professor of pediatrics, bone marrow transplant and immunodeficiency at the Cincinnati Children's Hospital at Cincinnati. He is recognized internationally as an expert in treating children and adults with LCH and HLH. He is also an expert in getting the diagnosis in patients with rare immunological disorders. He has many publications to his credit. He's a reviewer for index journals and has chaired many scientific programs. Each debater will have about 12 to 13 minutes. We'll have a rebuttal for a minute or two, and any questions will be taken at the end. So I will start with Dr. Scott, please.
Thanks very much, and thanks for the invitation and for allowing me to pick this fight with the estimable Dr. Kumar. Share my screen real quick. All right, does that look all right?
Yes, it does.
proceed anyway. All right. So Dr. Kumar and I have attempted to take opposite sides of this debate about the various criteria that we use to describe this entity I will call HLH/MAS. And so I am going to argue in favor of the existence and utility of such criteria. I have some disclosures. So what exactly are we talking about in terms of the criteria? And so here, these are sort of arrayed before you, the 3 criteria that, I will sort of lump together. These are the HLH-04 criteria developed by the Histiocyte Society, the criteria in 2016 from a group led by Dr. Cron and others to distinguish macrophage activation syndrome from systemic GIA, and then a more quantitative score called the H-score. And largely, if you look, they're quantitating a lot of the same parameters. Some of them are sort of a binary readout, and some of them, quantitate. But it's cytopenias, it's platelet count. We'll talk about the actual phenotype in a moment. But each of these criteria were not developed in the exact same context. So, the HLH criteria, as you're supposed to have 5 of 8. The MAS criteria have to have fever and high ferritin plus any of these 2. And then the H-score is really a continuous readout where sort of the best inflection point for sensitivity and specificity was at about 169. But perhaps more importantly is they were derived by interpolation from certain populations. So the HLH-04 were derived largely from children, and children who at least had concern for having primary HLH. By contrast, quite a different group of patients were used to describe or build these classification criteria for MAS. They were all patients who either had or strongly suspected to have systemic JIA. They also included some systemic infection controls to try and increase specificity. And then the H-score was done entirely in adults, none of whom, to my knowledge, had real causal biallelic mutations in HLH genes, the majority of whom had either malignancy-associated or infection-associated HLH. And so those changes in the background population really are among the most salient points of these criteria. Another important point is they're largely pretty old. The HLH-04 criteria were obviously established before 2004. And so, some of the newer biomarkers that are being tested, some of the newer technologies really haven't really entered any of these. And even though the H-score and MAS criteria are newer, they're still using largely the same tests. So before we get too far into it, I will concede a few points to the estimable Dr. Kumar depicted here around 1986 at the peak of his career. It is true, the individual components of these criteria are non-specific. And so if that is where we're going to get hung up, I've already conceded my loss. I will concede that there are some elements that are probably not even worthwhile having in any of the criteria. The NK function test is quite non-specific. Hemophagocytosis is neither sensitive nor specific. And then finally, I think where we're headed is that if we are to say that if you meet X criteria, in this case, probably the HLH-04 criteria, that you then need dexamethasone, etoposide, and that is your diagnosis, end of workup, well, then I concede as well, because that is categorically wrong. But obviously, I don't believe those things. A few of my rheumatology colleagues and I got together a couple of years ago, and this is a paper that is under review right now, trying to give practitioners some guidance at the earliest stages of this HLH-MAS entity. And so my non-official summary of that effort is that the description of HLH/MAS is as a state, not an etiology. And I think that that's an important sort of change in mindset for a lot of practitioners. There are lots of contributors to the state, infection, genetics, underlying diseases, and that most patients usually have more than one identifiable contributor. Finding these contributors and treating them is essential, but simultaneously so is recognizing that this is a syndrome. And finally, that the existing criteria are actually okay if you employ them in the proper setting. So we're used to this in the context of shock. And I don't mean this kind of shock, I mean this kind of shock, you know, the impaired delivery of oxygen to organs. We're used to having criteria that don't tell us what the underlying cause is, but that we nevertheless find useful. And so shock is a description, not a diagnosis. Shock is defined as a state, not an etiology, but a physiologic state in time of tissue hypoxia that is initially reversible, but you have to recognize it and treat it immediately in order to prevent or reverse that damaging physiologic state. And so we recognize that there are multiple things that go into shock, that it's not all the same. There's more and less severe, that it can change over time, but that you can recognize the physiology of the syndrome and that you can act on it in a way that is potentially able to reverse course or prevent complications. And so we recognize that there's categories of the different contributors to shock. And if we're going to continue the conceit of the umbrella, you know, shock is an umbrella sort of description, but that we already correct the physiology with fluids, oxygen, pressors, that kind of things. And we are simultaneously looking to manage the contributors, but we have to find them first, or sometimes we'll empirically treat for infection and that kind of thing. So we're all quite comfortable with this rubric. So can we define an HLH-MAS physiology? Well, you know, I would argue that we can, that the elements of all these different criteria are all roughly describing a similar end physiology that we call HLH or MAS, depending on context. So that includes systemic inflammation, some of the parameters here, including some of the newer ones that maybe tell us a little bit more about the specificity of that inflammation, being more of a T cell or an interferon gamma axis. You can measure interferon gamma itself, or CXCL9, which is a direct product of interferon gamma's effect on cells like macrophages. Hyperferritinemia is quite a sensitive marker of this. If your ferritin is not, you know, above 400 or 500, you are not in HLH right now. It doesn't mean that you're not trending in a rough direction, because this is a temporal diagnosis, but you know, ferritin is quite sensitive. You know, DIC, we read out in a number of different ways: dropping platelets, dropping fibrinogen, dropping sed rate for those of us where this is an easy test to get. You know, if you've got a really high CRP and a dropping ferritin, we all know to be concerned about that. And increasingly, I think we realize that there are other physiologies that overlap a bit with this component, and thrombotic microangiopathy is one of them. I won't get too far into that. Hepatosplenomegaly, we can talk about. Important to note that that is also a contributor to the low platelets because it sequesters them. And then the main organ dysfunctions that I think we associate with HLH, again, not specifically, but as part of a syndrome, are liver dysfunction and CNS dysfunction. So we can define this HLH-MAS physiology, and we can define it somewhat mechanistically as well. And I think Randy did a great job introducing this, so I won't belabor it. But we recognize there are a bunch of different kinds of contributors. There's cytotoxic cells that have impaired granule-mediated cytotoxicity. There's excess IL-18. There's all kinds of infections, and especially viruses. And then there's malignancies. But the sort of physiology that these all invoke that leads to HLH-MAS, we think is really centered around this immune synapse, where you have your cytotoxic cell and you have your target cell, in this case macrophage, could be a dendritic cell. And something about this interaction is excessive, exuberant, lasts too long, largely because of these different contributors interacting with each other. And you get this cytokine storm that is largely driven by interferon gamma, but there's lots of other targets as well. And that ultimately leads to the things that we're reading out as the physiology of this abnormal immunologic process. So what do we call it? And this is, I think, a legitimate problem with the whole criteria discussion, is that depending on who you ask, the name that they want to use for this overall syndrome is all over the place. Cytokine storm, HLH, MAS, it really sort of goes on. And the issue is everyone thinks that the name that they have is the best one, and it just adds another name to the list of potential things we could call it. And so we're at the point now where we kind of just need to pick a name. And I agree with Dr. Kumar, secondary HLH is probably not the best name, but I think agreeing on one is probably of the most utility to the providers out in the community. So to sum up, what good are having these criteria? Well, again, like the shock descriptive criteria, the HLH-MAS criteria help us remember to assess all of the physiology. You know, if your ferritin is high, well, now I'm going to pay more attention to coagulopathy. I'm going to make sure that I'm paying attention for liver and CNS dysfunction, and maybe I'll trend things a little better. So this criteria are good for cueing you for building out a broader picture of the physiology, setting up a monitoring plan. At the same time, they maybe key our brains, this is our brain icon, to investigate the right contributors. And this is really age and context dependent. There's no shortcuts. There's no single list that's perfect for every patient. You know, we don't routinely check for dengue in my institution because the incidence is so low, but we do look for things like ehrlichiosis. And then finally, and simultaneously, you recognize that this is a syndrome that itself is pathologic. And while you're doing these other things, you might begin certain treatments, certainly supportive care. You might start empiric antimicrobials because infection is such an important contributor to this physiology. You might think about prophylaxis because this is a sick patient who is at risk for infection or gastric ulcers or clotting. And you might want to treat, you know, the physiology. And Randy talked about things like anakinra or empiric steroids. And again, that physiology and that treatment, you hopefully want to move into context-specific treatment as quickly as possible, meaning treating those underlying contributors. So that's why I think these criteria are useful. We wanted to leave lots of time for discussion, so I will stop talking and turn it over to the estimable Dr. Kumar.
Thank you, Dr. Khanna. And now let's have Dr. Ashish.
Slides okay?
Look good.
Okay, all right. Well, thank you, Scott. I'm not sure how I'm going to repeat that, but I will try. Okay, so my disclosures are clear, and the biggest one is that I usually agree with everything that Scott says, except for the picture of me that he had with the box. But anyway, okay, so Scott has already mentioned some of this, so I'll quickly go over trying not to belabor that. That is one of the challenges, what's in a name? And we try all of these conditions are the same, interchange share some things, and that's where it ends. The similarity just ends there. Underneath, they're all very different things, many different diseases that contribute to this. We all know that. So we'll also like to use these terms: hyperinflammation, hypercytokine. Is there a normal level of inflammation? Just remind everybody that inflammation is a normal protective response, but ectopic or misplaced inflammation can be pathological. And this is where, you know, we all have been talking about this HLH as an example, and the diagnostic criteria that Scott just already introduced. I'm going to focus on class for an age score, and just as or those not even are established by the Society, and they basically stipulate that the patient had 5 out of these 8 clinical features: fever, splenomegaly, cytopenias affecting communities, hypertriglyceridemia or hypercytosis, lower absent NK cell activity, elevated ferritin, elevated soluble C5. In the absence of a malignancy, this patient would be diagnosed diagnosed as having HLH.
Dr.
And
Kumar,
current
sorry to
dog- Yes.
interrupt, but your audio is not very clear.
Okay, sorry about that. Let's give me 1 minute. I'm going to see if I can switch to my phone instead. Sorry. 1 minute. Okay, Chandrika, can you hear me now?
Yes, much better now.
Oh, is this better? Okay. Sorry about that. Let's share my screen again. All right. I will try and, in the interest of time, run through some of the things. So the current dogma states that if you have 5 out of 8 criteria from the HLH 2004, you have HLH. If you find a genetic mutation, we call it primary or familial HLH. If there's no genetic mutation, we call it secondary HLH. And we have heard, and all the papers state, that you must treat HLH quickly because it is serious, life-threatening. I'll give you one quick example that we encountered. This is a real patient, an 18-year-old male who has a history of Crohn's disease, developed fevers and leukopenia. He was found to have EBV based on the mono spot. Thought that by holding his 6-MP he would get better, but things actually continued, and he developed vomiting, diarrhea, showed up in our emergency department, found to be in shock, and at that point required lots of fluid resuscitation and norepinephrine drip, admitted to the ICU, noted to have splenomegaly, thrombocytopenia, leukopenia, and the concern was raised, could this be HLH? And sure enough, his ferritin was elevated, as was his soluble IL-2 receptor. We are in Cincinnati, where we get access to soluble IL-2 receptor. We send it in the morning, we have the result in the afternoon. We are a little spoiled. So based on this, his blood cultures were negative. He looks like he has HLH. So treatment was started with dexamethasone. He stabilized and came out of the ICU. However, this is where things get complicated, because within a day or two, fevers return, his anemia worsens, his hemoglobin is now down, his clinical condition worsens, his liver enzymes go higher, and his HLH markers actually also worsen. So the ferritin, which had come down to 5,000, is now 11,000. The soluble IL-2 receptor, which was 19,000, has now gone up to 28,000. He has mild EBV, but we knew that he had mono. But what about all of this? And so we have an 18-year-old with Crohn's disease, now diagnosed with HLH. He responded to dexamethasone, but is now reactivating. The discussion we had was, well, the standard therapy for HLH is dexamethasone and etoposide. Is this incomplete treated HLH? Should we add etoposide at this stage? And so here's a question, at least those of us who understand the slang in the US. What do you call a fake noodle? An impasta. We did a PET scan, and this is what it showed. As you can see, he has massive hepatomegaly, splenomegaly, and lots of PET avid lesions. This is his stomach in the middle. We did a gastroscopy and found several lesions spread throughout the stomach, and a biopsy of those showed a lymphoma,
which was EBV positive, and specifically this one was an EBV-associated plasmablastic lymphoma. This was several years ago, and since then we have identified several such patients who had an underlying malignancy that was initially thought to be HLH. We published our first paper now in 2018, where we described 9 such patients. Unfortunately, 8 of those did not survive. The only one surviving is the story who I shared with you. The interesting thing is this paper came out in 2018. The number 1 downloaded paper in 2018 from the same journal, Pediatric Blood and Cancer, was the HLH 2004 Diagnostic Criteria Guidelines. And so this is the problem with those guidelines. First of all, they were aimed specifically only for familial HLH. They are opinion-based. There is no evidence that these criteria are the right way to diagnose HLH. They were actually the entry criteria for a clinical trial called HLH 2004. The sensitivity and specificity of these criteria has never been tested. And this was not meant to be the definition of HLH. It was, these criteria were for enrollment on this clinical trial. But in today's world, anybody who has these clinical features, it is almost presumed that this is a definition of HLH. And as Scott has already pointed out, 2004 was actually 19 years ago. And the criteria were probably conceived much before that. People now use this thing called the H-score. Well, the gold standard against which H-score was developed was actually expert opinion, same as HLH 2004. There are newer papers coming out from the critical care literature that state that the H-score has very high sensitivity and specificity compared to what? Well, it's compared to either expert opinion or compared to fulfillment of HLH 2004. So what you have is truly this circular argument that the H-score relies on HLH 2004, and the HLH 2004 itself was opinion, and everybody just going round and round. And the challenge is this, that no level of ferritin, no matter how high, is specific for HLH, nor is soluble IL-2 receptor. None of these clinical features are specific to any cytokine syndrome or HLH. And as Scott already mentioned, hemophagocytosis, the disease is named after it. It is a very non-specific and actually not even a very sensitive finding. And in fact, we now know that in children with primary HLH, hemophagocytosis is sometimes never seen, or it's usually seen on autopsy, not during diagnosis. And our pathologists can find hemophagocytosis in almost every bone marrow that is done for a diseased state, any disease. And so all roads can lead to HLH. These are the diseases that we have seen that were misdiagnosed as HLH. These underlying diseases were never discovered. And I left this one here, name your disease. You can pick any disease and you will fulfill the criteria. And so what do you need in a storm? What else but an umbrella? And in this case, Dr. Scott Canna's umbrella. And essentially, the umbrella term, whether you call it cytokine storm, HLH, what we're talking about, that all of these diseases can present with that symptomatology. And which is why so what's wrong with then using these diagnostic criteria for assessing these terms, cytokine storm or secondary HLH or HLH syndrome? Why not call them that? Well, the problem is this, that our brain, our minds don't work in a rational manner. There is a slow thinking mind and a fast thinking mind. And in our fast paced world, especially in the ICU and acute care setting, we rapidly want to get to the fast way of making the patient better. So the first disease state that fits in the patient, we usually accept that as the diagnosis. And then when such a diagnosis is tightly linked with the treatment, the outcome can be very dangerous. And so this is what I mean by that we typically associate HLH with immune suppression, that the treatment for HLH is immune suppression. Well, if you have something like familial HLH and you put the patient on steroids with or without etoposide, yes, you are putting out the fire, the flames of inflammation. However, the patient actually has an underlying infection. You are now adding fuel to that fire. When we have recently seen that happen in many children with adenovirus, who died because they were given immune suppression. And so what do we do? I think this is exactly what Dr. Scott Kenna and I have been agreeing on, and that is recognize that HLH, cytokine storm, whatever name you want to give it, it is a description, like shock. It is not a diagnosis. And these criteria describe an inflammatory state, but they are not diagnostic of anything. And so once you recognize that there is an inflamed state, what one must do is search for the actual diagnosis that is under the umbrella before proceeding with any treatment. And then identify and treat the diagnosis, whether it is familial MAS, infection, or a malignancy. Now, there are challenges to diagnosing FHL in a timely manner, and we know that, but at least malignancies and infections can be identified rather quickly as long as we think of them. The challenge is that we many times don't even think of them. And so with that, I will end, and I'll be happy to take any questions.
In the interest of air safety and your personal safety.
Thank you, Dr. Ashish. I think, Dr. Scott, you have 1 minute for rebuttal.
Oh, rebuttal. I think we agree with each other. No. Yeah, I think that Dr. Kumar is incredibly right, I think, about one thing that perhaps we need to do is it's been 19 years. It may be time for a rehashing of those criteria, which is then, of course, going to usher forth the decision-making of what the right name is and even what the right use for them is. And I think that that's one of the reasons it's been so long that they have persisted, not because anyone who made them or uses them thinks that they are perfect, but that their replacement is such a thorny, messy issue. And I think you're absolutely right that we create a problem by not fixing the old one. Maybe being a little too conciliatory, given this is supposed to be a debate.
Thank you, Dr. Scott. I think this is the first time in a debate where I see both the protagonists agreeing with each other. So I think we have a couple of questions here. One is for defining HLH. What are the essential physiological alterations you must define? Any one of them can take it. Dr. Scott?
I'll jump in just because I think the airport is hopping wherever Dr. Kumar is. I mean, I think the ferritin, I don't think that we fully understand the physiology that drives ferritin in these patients. But it is a sensitive marker. It is wildly non-specific. But I think that is the place to start. When you have, clearly you have to have systemic inflammation. There are some features to the flavor of that systemic inflammation that are probably helpful when they're available. We can't get soluble IL-2 receptors back in anywhere near that time frame. So we sort of operate like the rest of the world without. So I think that those features of the physiology tell you that like you're in the ballpark. But I think that some of what I consider to be more damage or organ specific issues, the DIC, I think is a later finding, but one that you don't want to miss. And then the hepatic and CNS involvement. You know, I think those are the main things. I don't know if that answers your question. It really is sort of the whole syndrome.
Thank you, Dr. Scott. Now, two quick questions for Dr. Ashish. One is, can you please elaborate on the adenovirus-induced HLH and a bad outcome by immunosuppression?
So the problem is this. Just because they met the clinical features of HLH, do we call it HLH? What it was disseminated adenovirus sepsis that was mistaken to be HLH. And that is the problem, that just because you meet the criteria that are non-specific to begin with, we never defined that is the definition of HLH. So actually, if you look at every patient with a T-cell lymphoma, anaplastic large cell or any other peripheral T-cell lymphoma will meet the criteria. Every patient with viral sepsis will meet the criteria. Does that mean they have HLH, or do they just have viral sepsis? Nobody ever looked for that. So that is what happened in all of these patients who we have recently seen, that they were thought to have HLH. Nobody considered the possibility of adenoviremia. They gave them steroids. A few patients got etoposide. And by the time they got to us, they were sent to us for refractory HLH, but what they had was disseminated adenovirus. In the first few patients, we were unable to save them because they had disseminated adenovirus that caused end organ damage that was irreversible. And then in the other child, we were able to stop immune suppression, add antiviral therapy, and we now have viral-specific T cells available. That is how we were able to save the child. And we just got another case just this week for the same thing. So this is the challenge that we are facing. And so there's another question in the chat box that I saw, that shouldn't every patient with DIC will meet the criteria? Should they not be called HLH? In my book, no, they should not be called HLH. I mean, if you want to call them HLH, sure, but don't treat them as HLH with immune suppression, because there is no evidence that I know of that says immune suppression helps in somebody who has a disseminated infection.
Thank you. And this last question to you is that the indications for PET scan and bone marrow examination in patients who suspect HLH.
Yes. So if you go to our website, cincinnatichildrens.org, we have our own diagnostic algorithm, which basically says, consider all those diseases that are under Dr. Khanna's umbrella. And so we routinely, unless there's a family history and unless we already know genetics that tell us that this is primary HLH, we start with an open, very wide net, and we do PET scans in every patient. We do bone marrow biopsies, not to look for hemophagocytosis, but to look for leukemia, or sometimes we have found infection hiding in the bone marrow, including leishmania. People in India are familiar with Kala Azar, but not everyone. And we've had a recent child from Northern Europe who was found to have disseminated leishmaniasis that was misdiagnosed as HLH. And then, of course, my question was, where did he get it? Well, the family went on vacation to a tropical island 2 years ago, and that is where he acquired that infection. So the possibilities are endless. We just have to keep all of those in mind, that the genetic forms of HLH are actually much rarer. Leukemia, lymphoma, and infections are more common.
I think Dr. Singhi wants to say something quickly.
Yeah, I think the debate really has highlighted the issues, and both of you have tried to address some of the very important issues. But I think one factor which is missing is a good marker of inflammation. And by the time we recognize inflammation, it's late. So what would you suggest besides what we have in the criteria as the inflammatory marker, which may be more reliable? And second thing, you have already made the point that every HLH diagnosis must be supported by a bone marrow. Without bone marrow, you would make a lot of mistakes. And leukemia is just one example. Various infections can cause leukopenia, thrombocytopenia, and anemia. And then you need just two more criteria, and that's end. So hepatomegaly will occur with them, splenomegaly would occur, there may be DIC. I wouldn't at least suggest anybody to treat them. So two questions: what is the best inflammatory marker you would like us to, and then when should you start the treatment?
So I'll tackle that, because I take issue with one of those statements. But your question about inflammatory markers, I actually think that we have the tests to, first of all, inflammation is not one thing. There are axes of inflammation that, the kind of inflammation that is in MISC is fundamentally different than the kind that's in familial HLH. And there are, mechanistic and biomarker data to support that. I think in general, C-reactive protein and ferritin do a pretty good job and are quickly available. and will tell you, you know, how concerned you are. Of course, you're going to have blood counts and other things that raise your level of concern there. But I think that these are, you know, good places to start, and I'm glad to see more and more places adding ferritin to their sepsis algorithm. Not because it tells you every patient needs steroids and etoposide. That is the wrong message to take from that. The right message is to say that hyperferritinemia is associated with a certain kind of inflammatory physiology and worse outcomes, regardless of what got you there. If you have cancer and your ferritin's very high, or bacterial sepsis and your ferritin's very high, outcomes are worse. And that is the utility of that. I'm a rheumatologist. When I have a patient who either has known or looks to all the world to have systemic JIA, I can't remember the last time we did a bone marrow biopsy on those patients. So I think that context is critically important. Yeah, if you've got an older child or an adult, you really need to not stop looking for lymphoma. And sometimes you still don't find it. I mean, there's these stories of PET negative splenic biopsies showing lymphomas. So it's hard to be reassured against lymphoma. In my population of rheumatic disease patients, and I know Grant agrees with me, and the Cincinnati group is doing this way more than we are, we've been using IL-18 to sort of decrease the number of bone marrows that we do, because we kind of know that there's almost no malignancy that gives you an IL-18 value of 75,000. And so if I get that back, I can say, well, I was never really concerned that this was malignancy to begin with. I don't care if I see hemophagocytes. And now I have this test that further de-risks that. I'm not going to do a biopsy.
I don't think I have anything else to add other than just repeat what we've already said, that HLH or cytokine storm is a physiologic state. It is not a diagnosis. And so you can choose whatever you want. There is no specificity to any of these markers. There are papers that keep coming out saying that the soluble alpha receptor to ferritin ratio or a particular ferritin value, none of those are absolute and specific. If you're looking for the magic bullet that will give you the aha, I've got it, I'm sorry to tell you that one does not exist. The only one that comes close is what Dr. Khanna just said, that in the context, if you know the patient has a history that is suggestive of systemic onset JIA or any other type of JIA or lupus, and now their IL-18 is sky high, I think that is a safe bet that they have macrophage activation syndrome. But short of that, all the others, you really have to look for what is the underlying driver. And that underlying driver, you have to take a thorough history, and you have to keep an open mind that it could be anything. We had a newborn baby who we found to have anaplastic large cell lymphoma, which looked exactly like familial HLH. And in newborn baby, we would have never suspected a lymphoma, but that is what the lymph node biopsy showed. So unfortunately, there is no magic bullet. You just have to look for all of these things and keep an open mind. And this is where the challenge of starting immune suppression without a diagnosis, or at least considering of a diagnosis. Unfortunately, a lot of these things for us, they happen on a Friday afternoon where you don't have the diagnostic capabilities. So at least we will obtain a bone marrow biopsy and then begin steroids if we suspect that, unless we know for sure that this is not leukemia or lymphoma.
I just have one question.
They were having a bone marrow examination, right? Because we have a lot of infections in hematology.
So I just
so always look for infection. Sorry, Chandrika. Yes, go ahead.
Yeah. So you said the main issue with giving them a label is the immune suppression that we subject these children to. So probably steroids, etoposide is something you're worried about. But what about drugs like anakinra, which probably wouldn't cause much harm even when we use it before we get a diagnosis?
Yes.
That is unwilling.
Yes. I think this is where Dr. Krohn and we were just chatting about that, and I completely agree with yes. as long as we use an agent that does not obscure the diagnosis, so either anakinra, imapalumab. I am a big fan of anakinra, especially when used at higher doses. It helps reduce the inflammation, and it preserves the ability to make the diagnosis. That is the problem with steroids, because they are a very good drug for lymphoma and leukemia. And so after you've done steroids and then you've done the bone marrow or the lymph node biopsy, all you get is necrotic tissue. We've seen that so many times, and that is why anakinra and imapalumab, if and when it becomes available, until you get the definitive diagnosis. Yes, completely agree.
Thank you.
Thank you very much for that very stimulating debate. And I hand it back to Dr. Chandrika for the next session.
So thank you to Dr. Scott Khanna, Dr. Ashish Kumar, and Dr. Jagdish Chinappa for that wonderful debate. I would just request our speakers to kindly take up questions in the chat box, because there are a lot of questions there which we may not be able to take it after every talk. So with this, I now request Dr. Dinesh to kindly introduce our next speaker, please.
Hi. It's a pleasure to introduce Grant Chuluk. He's an associate professor of pediatrics in Division of Rheumatology, Cincinnati Children's Hospital Medical Center, Department of Pediatrics. He has done his PhD and his fellowship in pediatric rheumatology from the same center. His research focuses on the pathogenesis of severe inflammatory disease of childhood, in particular systemic juvenile idiopathic arthritis, macrophage activation syndrome, and SGI-associated lung disease. Just after Randy's talk, we had a lot of discussion about genetics, DOC8 and DOC2 mutation and how it's going to help in the management. And Dr. Grant is going to talk to us about when do we order genetics in cytokine storm. And so over to you, Dr. Grant, about
thank you very much.
Cytokine storm, when to consider.
Thank you very much. You can see my slides all right?
Yes. We can hear
Perfect. Well, thank you very much for the invitation and the opportunity to join this amazing meeting and panel, and to follow my good friends and colleagues, Dr. Crone, Dr. Khanna, Dr. Kumar, who absolutely likes to consult me at 4 o'clock on a Friday for these questions. So I will spend the next 15 or so minutes talking about this question of when to think about ordering genetic testing in cytokine storm syndromes, what we're talking about when we're talking about genetic testing, and how to think about interpreting that. And the spoiler is that it's not an easy answer from a clinical decision-making perspective. Just my quick disclosures. So again, I'm going to first talk about what we know about some of the genetic contributors to severe cytokine storm syndromes in children, and then some of what goes into the pro and con decision for doing genetic testing in such patients. So this idea of cytokine storm syndrome, which we've been talking about over the course of today and the next couple of days of this meeting, had been sort of percolating in the literature in the couple of years prior to the COVID-19 pandemic, and has really kind of taken off in the last few years. This lovely book that many of us contributed to by Ed and Randy, that came out just in time to help us craft how we thought about COVID and some of the COVID-related complications, I think was very, very timely. So when we talk about cytokine storm, as we've said, we're talking about a shared phenotype that is caused by a whole bunch of underlying triggers. And we see that clinically in things like hyperinflammation with hyperferronemia, as multi-organ system failure, from what I think of as unchecked and unconstrained and amplified immune responses, particularly that are cytokine driven. And I think if we did a drinking game for every time we showed Scott's umbrella, we wouldn't make it until Saturday. But I think it's helpful because it gets a lot of our diseases and concepts here under the same rubric. I think that the cytokine storm syndrome nomenclature is very helpful because it helps us understand that there can be a shared immune-mediated pathogenesis in what on their surface seem like very, very different diseases. And as I say, when we see a patient who may clinically fit into this, as the debate was saying, that's not the answer. It's a sign to look under the umbrella to try to figure out what of these possible pathogenesis is happening. And so this idea can be problematic when we oversimplify this, because these are not all created equal. Not all of these have the extreme hyperferritinemia that we see in things like HLH and MAS. Not all of them are extreme IL-6 apathies. And their natural history is quite, the most extreme examples certainly being the cytokine release syndrome induced by CAR T cell therapy, which is by definition a self-limited process, versus full genetic familial HLH at the other end of the spectrum. So when we're thinking about cytokine storm syndromes, which have a very strong genetic role, really familial HLH is our model. And so in the various genetic defects that drive familial HLH, they really converge on this problem of cytolytic killing CD8 cells, as Randy discussed. So as this happens normally, cytolytic lymphocytes recognize their target. They have this really complex cytoskeletal machinery that involves the creation of this immune synapse, movements of these cytolytic granules containing perforin and granzyme to that point of contact, and ultimately the release of those into target cells leading to their killing. And the various forms of familial HLH are due to defects in various parts of this pathway, the most common identified of them being perforin deficiency itself, but several other genetic players, and other things that we probably haven't figured out. Randy's worked in the last several years on DOC8. However, likely there are other ones that can lead to a full genetic defect in the inability to do this, and therefore an extreme predilection towards cytokine storm. So as a pediatric rheumatologist, I think a lot about macrophage activation syndrome, or MAS, which was noted by my mentor, Alexei Grom, and others, to have a real strong clinical similarity to that familial HLH model, and that had been led by work from Lisa Filipovich and Mike Jordan and others at Cincinnati when Dr. Grom was training. And that, if you go through those HLH criteria, which we've bemoaned, I would just note that you can see all of these to some degree in macrophage activation syndrome, right? Certainly they have fever, extreme hyperferritinemia, splenomegaly. Things like the cytopenias and the hypofibrinogenemia can be sometimes complicated because you have this sort of push and pull where there is a very exuberant acute phase response in systemic JIA that's pushing platelets upwards and the fibrinogen upwards versus this cytokine storm process that's leading to cytopenias and hypofibrinogenemia. And sometimes you end up with someone who is clinically overt MAS, but sort of a low normal range of platelets and hypofibrinogenemia that wouldn't necessarily fit the HLH-04 criteria. The difference, though, is genetics. That familial HLH, as its name implies, is a familial process. So what about genetic defects in macrophage activation syndrome? This is something that, that Dr. Grom and then my own work has been thinking about for a while. He and others in the field had reported both some case reports and then large case series, particularly by Bas Foster and colleagues at Utrecht, showing that many children with systemic JIA, and particularly those whose experience overt MAS, have hypomorphic but functional variants in these HLH-related genes. And then a very comprehensive study by Ken Kaufman, John Harley, and Alexei Grom here found when they looked at a large cohort of children who had JIA and performed trio whole exome sequencing, they found that more than a third of them had known pathogenic variants in these HLH-related genes, which was significantly higher than you see in systemic JIA without MAS. Notably, if you look at those other columns of what they've called new genes, and they looked at genes where patients were either homozygous or had compound heterozygous mutations looked potentially pathogenic, as well as those de novo variants. If you did pathway analysis on those various genes, you found that there was a strong enrichment in granule trafficking and cytoskeletal related genes, again, supporting there being a number of other genes that we haven't figured out their function yet that may contribute to this process. Other work from our team has, as Randy alluded to, found that we see similar percentages of these in MAS, HLH in the setting of other severe diseases, particularly H1N1 cytokines. So there is likely a genetic role in things like MAS and some of these other cytokine storms, but it's not a single gene process and it's not a universal finding. So how do we think about this relationship between genetics and the risk for cytokine storm? And there's been several versions of this slide. Ed has put one together. Mike Jordan and Kim Risma have done that. Fabrizio De Benedetti has done this. This is one that Keijin Zhang and I have put together, where basically if you think about the risk of cytokine storm, you see a much higher risk with more genetic burden. With the highest risk being in those categories of patients who have familial HLH, where they have pathogenic biallelic cytolytic pathway variants, where they will experience these life-threatening episodes of cytokine storm syndrome, triggered by sometimes very common infections, sometimes really nothing that can be identified. Whereas in the middle, yes, we see genetic variants that are likely important for this disease pathogenesis, but they're generally only manifesting a clinical cytokine storm in the setting of something else, whether that's a very active or untreated rheumatic disease, a severe infection, a malignancy. So getting to the point that even if there are genetic risk factors, there is likely still an underlying trigger in these patients that needs to be identified and likely treated. So the ones we need to find are those on the right end of the spectrum. So how do we think about that in doing genetic testing? So when we talk about genetic testing, that's sort of a catch-all term for a lot of different things that we can do. It can include single gene testing, which in this type of a field we're rarely doing because it's not like, there's the cytokine storm gene and we should test for that. More often we're talking about things like panels. There are a number of them that are commercially available or that are done by academic labs such as ours that test for increasing numbers of genes. Periodic fever syndrome panels, HLH panels, including a rapid one that will get you results, at least in the US, within a couple of days. And then broader ones that look for autoinflammatory, primary immune deficiency, or immune dysregulation syndromes that look at several hundred genes. And then finally, what we often end up sending on patients who are critically ill is whole exome or whole genome sequencing. So we're going to give a couple slide crash course in next generation sequencing, which is sort of this catch-all term that describes a couple of different technologies for doing this high throughput sequencing, which have become transformative because of their scalability, their speed, and their associated decreased cost. So what they do is comparison to Sanger sequencing, which people my age and older maybe have done in the lab in our training, refer to a number of techniques that can track the addition of nucleotides to small sequences of DNA in real time, but then can make this massively parallel so that they simultaneously sequence millions of these short fragments of DNA in a sort of shotgun way, and then computationally align those to the reference genome to identify potential variants. And that's the trick with next generation sequencing. Doing the sequencing is actually very easy. We have a sequencer in my lab. People in my lab, we can get you a whole genome sequence data in a few days. The trick is the analysis. And this is sort of a broad overview of how that happens. So what happens is you get that raw data, you align that to the genome, you figure out where all those little shotgun pieces go, and then you look and figure and try to find your variants. And you compare that to basically the quote normal, which is what a majority or plurality of people have at each position in the genome. Then they do some quality control. They look for ones, well, we didn't get coverage or we didn't get good sequences. We try to figure out what we're going to say corresponds to there being a homozygous at a position or a heterozygous at a position. And then you end up with tens of thousands of potential variants that are different from the normal, which is what we expect. We're all different from one another. But how do we figure out what of those are the things that make me, me, and you, and which are the things that are potentially contributing to a life-threatening disease? So then this is where the art of things come in. Generally, we throw out things that don't change a protein sequence, which may or may not be a mistake. We then focus on things that are rare, because these diseases are rare, and probably really important changes in our DNA are not very common. So sometimes we'll say things that are occur less than 1% of genomes. Sometimes we say even more rare. And then we end up with a low list of 1,000 to 2,000 variants. And then we got to figure out what those are. And that's the cost and the time of this process, because you have to pay a smart person to go through those and try to figure out what's important and what's not. So a quick example of how this is done, some of the very nice work of gene discovery really shows how this was done in sick patients who they didn't have an explanation. This is maybe one of my favorite stories of gene discovery, which was the identification of the ADA2 deficiency by Dan Kastner, Ivana Aleksandrievich, colleagues, and a large team. And they had identified multiple families that had multiple kids who had this early onset stroke and vasculopathy phenotype, which suggested a recessive disorder. So they performed sequencing, as we described. They went through this pathway, right? They then found those rare variants, and again, found a couple, 1,700 or so of them in each family. But then again, they thought this was going to be a recessive disease because they had healthy parents, multiple sick children. So then they looked and said, okay, what are the genes in one of these families where you have either a homozygous recessive or a compound recessive, where you've inherited one mutation from each of the two parents? And then you've got a nice, much more manageable list of sub 20. And then they did a very complicated Venn diagram where they compared those two lists, and they found one gene, which is the one that is the causative, which codes the protein of adenosine deaminase 2. And then certainly there are a lot of beautiful functional testing to show that this is really the problem. But this is an example of how you can do this and filter things down from all of this genetic mutation data to possible causative genes. So when I'm talking to families about genetic testing, what I say is, well, we're going to get one of three outcomes. Maybe we're going to get a home run. We're going to send this and we're going to say, aha, you have this mutation. We've seen this before. It's associated with a disease that looks somewhat like what this child has. This is positive. We have our answer. We might come back and say, we got nothing. And really, we never find nothing, right? Because as I said, all of us are different from everyone else. When we say that it's normal, we basically said, we haven't found anything that looks intriguing. And different companies have different ways of making that cutoff. Sometimes this is the advantage of doing things on a research basis when it's not such a life-threatening emergency, because then you can really delve into things, or doing this with a pipeline that you have a good relationship with, so that you can kind of understand what their threshold is for not normal. For example, we recently did a reanalysis on a patient who ended up having SAVI, sting-associated vasculopathy of infancy. They'd had this done, they'd found a variant, but it hadn't been in a region that was characterized yet of the protein. And so they just said, yeah, we got nothing. But it turns out they'd seen a mutation, they just didn't report it. So then sometimes what they're going to do is they're going to report some of those variants of eminent significance, which are basically changes in genes that look interesting that we've never seen before. Or potentially pathogenic variants in things that don't really seem like they fit the clinical picture that you're giving. And this can be really complicated, and why you need to have a good relationship with your clinical geneticists, your immunologists, to help understand, is this something that is important and could potentially drive changes in therapy, which is really the question we're asking when we're doing genetic testing. So the limitations of doing these big, broad approaches, like particularly whole exome sequencing, as I said, you've got a lot of variants of unknown significance. You can actually request that raw data from a company. I actually have it here from a patient I just saw in clinic last week, and they'll tell you the hundreds or thousands of variants that you found. So if you really want to know, they'll tell you. And often you really need functional studies to really prove that something is important. We're we're beginning to move away from whole exome and more towards whole genome sequencing as the technology and the analytic pipelines are improving, because there are some disadvantages of whole exome. Whole exome, again, really only targets those coding parts of proteins, which excludes 98% of the genome. And so we don't look at those areas of introns, promoters, energetic reasons. Of course, the glass half fulls, we don't know a whole lot about them anyway. So even if we find changes, we don't necessarily know what those mean. But of course, that's sort of a catch-22. If we don't study them, we're not going to figure them out. And we know from other studies that there's likely a very significant contribution to genetic disease that comes from those non-coding variants. And because we do this exome capture to try to enrich for those, we get uneven coverage. So we sometimes, there are areas that we potentially miss or we don't get good coverage from. We're also not very good at seeing insertions or deletions when we do that. And so there's a move towards whole genome sequencing, which I think is appropriate because we get some of that data and we can start figuring out what more that means. So when I'm talking to my partners, my colleagues, patients about genetic testing, I say, well, there are pros and cons of doing it. And the pros are that obviously the chance that we can get an answer and we can end, we can sort of end the mystery of what's going on with this child. And often that one is so strong that when we have a child who's critically ill in the ICU and we don't have an explanation, I generally lean towards saying it. Because even if it's a low percentage shot, it's not a no percentage shot. Because if we do find severe inborn areas of immunity or familial HLH, it can suggest specific treatments, and particularly in identifying things like HLH, finding bone marrow, the idea of a bone marrow transplant becomes on the table. It can help you with it is sort of an atypical or presentation of something that's more common. And it can also help facilitate insurance approval, right? If you find that there's a genetic cause of a potentially an autoinflammatory syndrome or such, that you can say, well, now this is a rationale to treat them with biologic therapy. The cons and the things that really are less sort of cons or things you should know going into the process. It can be expensive, although it's getting cheaper. It can be time consuming, although as I said, it's getting faster. It can be negative in the presence of disease. So negative genetics doesn't mean that they don't have a genetic disease. It just means they don't have a genetic disease we understand. And again, it can hit that murky middle of the variant of unknown significance. And then I should also say it's not always needed for diagnosis. Right, is if there are clinical immunological features that are supporting a diagnosis, I don't think you need to wait for genetics to think about how you're going to treat this. So in conclusion, cytokine storm syndromes, which are an overlapping group of disorders, can have a very diverse set of triggers, but that can include rare inborn areas of immunity and familial. An early identification of those can lead to changes in treatment, particularly consideration of ENT. Genetic testing has become increasingly accessible, particularly in the US, but there are limitations and it may not always provide a clear answer. So with that, I'm very happy to take any questions about this. And again, thank you for the opportunity to be part of this great conference.
Thank you, Dr. Shoaib. I think we had quite a bit discussion about genetics in the earlier sort of lectures. And is there an age criteria for you and I know you elaborated quite a bit about the panel and other things, and not everything is available in India. What would we like to know is there especially suppose infants presenting with HLH or cytokine storm, would you have a lower threshold for the genetic testing compared to the older children?
Absolutely, absolutely. I think, and critically ill infants we don't have an explanation for. I think we should be reflexing to sending this early and often. A lot of nurseries at large centers in the US have been trialing these sort of rapid trio genome exome pipelines for infants who are born who have sort of critical illness right out of the chute, with showing actually a pretty high hit rate for identifying these things early. So yeah, the older they are, the less confident I am that they're going to have a genetic cause, right? A teenager who had 17 healthy years and suddenly is in your ICU critically ill, I'm less confident that we're going to find something on genetic testing.
would you suggest that, genetic testing first compared to bone marrow, or bone marrow should be done and all? That was one discussion which we had earlier.
Yeah. And actually, we talked about this at another meeting I was at a couple weeks ago about functional immunological testing for inborn errors versus this. And I say, another US reference, it's like, would you like beer or tacos? And the answer is yes. So I think that, in a critically ill child, you move forward with all of these. You say, we need to talk about doing a bone marrow to rule out malignancy. We should be sending genetics. We should be sending some of these more potentially specific immunological tests if available to try to define this.
Thank you very much. And I just sort of think there's some question, which is, no, Dr. Sanju has raised a question. See, we have a lot of children post-dengue. Dengue fever is quite common in India. And typically they present with hyperferritinemia or HLH following the day 7, day 8 illness. Should we be sending genetic testing in those type of children when the etiology is quite obvious?
Right. Yeah. And I, from a clinical perspective, I don't think it is going to really help drive your management. Again, I think from a research perspective, to understand what is the pathophysiology of why this is happening so we can better understand it, I think it's really an interesting question of that overlay between genetics and the trigger. But in patients where there's an identified trigger, yes, I think there is often a genetic component, because most people who get dengue don't end up critically ill in your ICU. Just as most patients who have leukemia and lymphoma don't have a life-threatening HLH response, HLH-like response, sorry, sheesh. But it's not, the answer is still treat the underlying problem. It's treat the infection, it's treat the malignancy, and support them through that, which can include degrees of immune suppression depending on the clinical state. But it's really identifying somebody who needs more definitive therapy for a genetic disease, whether that is, antibody replacement for an immune deficiency or other, or going towards bone marrow transplant.
You were suggesting about, there are some who would actually land up with bone marrow transplantation, other things by doing this thing. So that's how probably what you're suggesting.
Yeah. Although I would give the caveat of, we've transplanted patients who act like familial HLH. They keep getting these episodes, even though their genetics are normal. And gets to that question of, just because the genetics are normal doesn't mean they don't have a genetic disease. And again, that's a caveat to think about when you go into this, that it's not an all or nothing, black and white answer.
Okay. Thank you, Dr. Grant. And I think we're already running a little late behind time, so I'll hand over the proceeding to Dr. Chandrika, who can sort of.
So thank you, Grant, and thank you, Dr. Dinesh, for that wonderful session. It's my absolute pleasure to introduce the chairpersons for our next session. So Dr. Suneet Singhi, sir, he's a global leader in pediatric intensive care. He successfully established India's first PICU way back in 1992. He's a fellow of American College of Critical Care and of IAP. Sir has also been a visiting professor to Boston's Children's Hospital in USA and Astrid Lindgren Children's Hospital in Sweden. He was a senior professor and head Department of Pediatrics at PGI Chandigarh. And he also developed India's first DM course in pediatric critical care. He has also been the president of World Federation of Pediatric Intensive and Critical Care Society. So we welcome you, sir. Dr. S. Balasubramanian is our next chairperson. He's the medical director and head of Department of Pediatrics at Kanchi Kamakoti Child's Trust Hospital. He's also an honorary pediatrician at Southern Railway headquarters in Chennai. He has around 100 index publications and has chaired 600 CME sessions with many orations. He's a distinguished DNB teacher awardee from NBE, and he has also received the Lifetime Achievement Award from Tamil Nadu Dr. MGR Medical University. And he has been the chairperson of IAP Infectious Disease Chapter in 2022. So welcome, sir. And Dr. Arvind Shenoy, he is the clinical director of neonatology and pediatrics at Rainbow Children's Hospital, Marathalli. He was the former chief neonatologist and medical director at Cloud9 Hospitals. With this, I request Dr. Suneet Singhi, sir, to introduce our first speaker for session 2, Dr. Timothy Cornell. Thank you.
Thank you, Chandrika. It's a privilege for me to introduce Dr. Timothy Kaur.
So thank you, Grant, and thank you, Dr. Dinesh, for that wonderful session. It's my absolute pleasure to introduce the chairpersons for our next session. So Dr. Suneet Singhi, sir, he's a global leader in pediatric intensive care. He successfully established India's first PICU way back in 1990.